Good day, everyone. My name is Dr. Julian Owen, and I'm an intensivist at Hamilton Health Sciences, stationed at the Hamilton General Site, working in a cardiovascular intensive care unit and neurotrauma unit. I have a strong interest in renal replacement therapy and specifically continuous renal replacement therapy, or CRRT, responsible for the program at HHS and the education. I'm here to talk to you today about this in terms of when to start, as well as the prescription of CRRT. The specific topic I will speak to you about is renal replacement therapy: when, how, and why. I have no disclosures to report. The objectives of this talk: I'm going to review acute kidney injury in the ICU, its incidence and importance. We will review the KDIGO AKI staging, the types of renal replacement therapy, as well as the literature around when to start it in the ICU. We will review intermittent dialysis versus continuous forms of renal replacement therapy, as well as discuss CRRT prescription and therapy monitoring. To begin, acute kidney injury in the ICU or in hospitalized patients is very common. It is defined by a serum creatinine rise of 26.5 micromoles per liter within 48 hours, or an increase in the patient's serum creatinine from baseline by 1.5 times within 7 days, or by a urine output criteria of less than 0.5 mils per kilo per hour for at least 6 hours. The acute kidney injury network provides staging, which is very similar to the rifle criteria for chronic kidney disease. Stage 1 is defined as very similarly to the definition of AKI, having a serum creatinine rise of 1.5 times normal up to 2 times the patient's baseline, as well as an increase of greater than 26.5 micromoles per liter. There is an additional urine output criteria of less than 0.5 mils per kilo per hour for greater than 6 hours. Stage 2 occurs when the rise in creatinine is 2 to 3 times baseline, or the urine output is less than 0.5 mils per kilo per hour for more than 12 hours. And stage 3 is defined by an increase more than 3 times the patient's baseline creatinine, or a rise greater than 354 micromoles per liter, or any requirement for renal replacement therapy. There's additional urine output criteria listed there of less than 0.3 mils per kilo per hour for 24 hours, or anuria for 12 hours. In the ICU, rises in serum creatinine that meet the definition of AKI occur in greater than 50% of admissions. They are associated with an increased length of stay and mortality. And it's important to document AKI in the ICU, as it does long-term become a risk factor for development of CKD and end-stage renal disease. Risk factors of AKI include increasing age, presence of things such as heart failure and liver failure, or prior chronic kidney disease, anemia, exposure to nephrotoxins, including medications or contrast. Sepsis itself is a risk factor for AKI, even without hemodynamic perturbations. Shock and decreased renal perfusion is a strong risk factor and one of the most common ones we see in the ICU. Use of mechanical ventilation, as well as exposure to surgery, especially things like cardiac surgery, are associated with AKI development. In terms of markers of kidney injury, one of the earliest signs that we see is a decrease in urine output. The creatinine is the basis for the Aiken staging of AKI, but it often lags behind renal injury. There are some novel biomarkers that have been developed, including serum and urinary NGAL, kidney injury marker 1, cystatin C, insulin-related growth factor binding protein 7, as well as tissue inhibitor metalloproteinase 2. All of these biomarkers while they are novel and do predict AKI earlier than things like creatinine and urine outputs, unfortunately, they're not commercially available in many cases, and they still are unable to sensitively predict who will need renal replacement therapy. Progression of AKI can sometimes be determined by the intact tubular function, which can be assessed with use of things like the furosemide stress test. In a furosemide naive patient, usually 1 milligram per kilogram is used, or if they have been exposed in the past, a dose of 1.5 milligrams per kilogram is used. If urine output increases to greater than 200 milliliters in 2 hours after furosemide is given, would suggest some degree of intact tubular function. Whereas if the patient does not produce 200 mils of urine, it does predict progression through the stages of AKI. Although still, this test has not, unfortunately, been predictive of who will require renal replacement therapy. Now we'll review timing of renal replacement therapy based on current literature. The very first trial to examine this was published in New England in 2016, known as the Akiki trial, which was a multi-center RCT across 31 centers in France and involved 620 patients with stage 3 AKI who were receiving mechanical ventilation, vasopressors, or both. The intervention arm was early renal replacement therapy started within 6 hours, with the control group being late renal replacement therapy started only when patients met traditional, usually absolute criteria for dialysis. Their outcome was 60-day mortality. Results of this trial showed no difference in the primary outcome of mortality, with 48.5% of patients versus 49.7% of patients in the early versus late arms. And important to note, only 51% of patients in the control arm or delayed treatment arm actually needed renal replacement therapy. This trial was largely done in a medical surgical population of patients, many of which had sepsis and septic shock. Published the same year in JAMA was the Elaine trial, which was a smaller single center RCT in Germany. 231 patients with stage 2 AKI were randomized to early renal replacement therapy within 8 hours, or again, late renal replacement therapy when traditional absolute criteria were met. Important to note in this study, very different than the Akiki population, 93.5% were surgical patients, and the majority of those were cardiac surgical patients. Their primary outcome was 90-day mortality. Results of this trial actually did show a statistically significant difference in mortality favoring the early initiation arm, with a mortality rate of 39.3% versus 54.7%. Number needed to treat was 7, but because of the small numbers of this trial, the fragility index was just 3. And in this trial, a great majority of the delayed or control group ended up requiring renal replacement therapy, with the main reason being persistent AKI rather than absolute criteria. A follow-up trial published in New England 2018 was the IDEAL ICU trial. It was a multi-center RCT across 29 ICUs in France. Unfortunately, the trial was stopped early for futility, and they enrolled just over 50% of patients in their planned study. 488 underwent randomization. These patients had septic shock and severe AKI as defined by rifle class F. They randomized patients to early renal replacement therapy within 12 hours versus late or delayed within 48 hours if there was no renal recovery, and their outcome was 90-day mortality. In this trial, again, stopped for futility, there was no difference in mortality between the groups. And again, we saw a trend towards the delayed treatment group, over 1/3 not requiring the renal replacement therapy. The follow-up to these earlier trials and the trial that was meant to definitively answer the question of early versus late initiation of renal replacement therapy was the START AKI trial published in New England in 2020. This trial was monumental and eclipsed the previous trials with involving 168 hospitals across 15 countries and almost 3,000 patients. Patients had to have KDIGO stage 2 or 3 AKI, and they were randomized to early renal replacement therapy within 12 hours or delayed renal replacement therapy when they met absolute indications or had persistent renal dysfunction at 72 hours. Their primary outcome was 90 days mortality. The results of this trial showed no difference in their primary outcome. As you can clearly see by the Kaplan-Meier curves, the difference was 43.9 versus 43.7% mortality. Again, the trend towards the delayed arm patients not requiring renal replacement therapy, with 38.2% not requiring this treatment. And because of the size of the START-AKI trial, they were able to do some post-hoc analysis, and in their sensitivity analysis, whether it was stratified in terms of surgical or medical patients, sepsis or no sepsis, across all of these subgroup analyses, they did not find any difference for any particular group in early versus late initiation of renal replacement therapy. This trial has generally served to change practice and inform us on when best to restart renal replacement therapy. Now, is it ever too late? When is late too late? To answer this question, in Lancet 2021, there was the AKIKI 2 trial published, which was a multi-center RCT across 39 ICUs in France. They enrolled and randomized 278 patients with stage 3 AKI and who were receiving mechanical ventilation, vasopressors, or both, and additionally had AKI beyond 72 hours. So this would have already been enrolling patients in the late arm of the AKIKI trial. And they had to have a urea between 40 and 50 millimoles per liter. The intervention group underwent renal replacement therapy within 12 hours of meeting these criteria, whereas the control group, again, it was a watchful waiting approach unless they met absolute indications or the urea rose to above 50 millimoles per liter. Their outcome in this trial, largely driven by the small numbers, was 28-day renal replacement free days. And although they did look at mortality and others as secondary outcomes, their primary was renal replacement therapy free days. The primary outcome was not significant, so 12 versus 10 days free of renal replacement therapy. And there was no difference in essentially all secondary outcomes, with the exception of 60-day mortality. There was no difference, however, at 28 days mortality. And so I think at this stage, this is exploratory, but it certainly was not powered to look for a mortality difference at 60 days. 21% of patients in the control group did not receive renal replacement therapy and still recovered renal function despite the AKI beyond 72 hours. Post-hoc analysis of other trials, including the AKIKI and START-AKI trial, do indicate a concerning finding of patients that were in the delayed treatment arms. When they did eventually require renal replacement therapy, unfortunately, they had the highest mortality of any group. In the AKIKI trial, this was up to 62%, and in the START-AKI trial, 51%. So while these trials did not show a difference in early versus late initiation, it seems that patients in the control arm, where watchful waiting approach was undertaken, who eventually did require renal replacement therapy, seemed to fare the worst. And this highlights that we continue to need better predictors of who will need renal replacement therapy. Recognizing this is a post-hoc analysis, it is an interesting trend that is demonstrated. In summary, when do I start renal replacement therapy in the ICU based on all the available literature? Certainly, if someone has absolute indications for renal replacement therapy, things like dialyzable toxin, persistent refractory hyperkalemia or acidosis unresponsive to medical therapy, or volume overload unresponsive to diuretics, where you're having difficulties oxygenating a patient, those would be absolute indications and when all of us would start renal replacement therapy in the ICU. For AKI, Based on the results of the START-AKI trial and others, a watchful waiting approach is probably best, and delayed initiation unless the patient meets absolute criteria. And these were the criteria in the control arm that were used in START-AKI. So a potassium over 6, pH less than 7.15 or bicarb less than 12, or a PF ratio less than 200 with fluid overload. For others with persistent AKI beyond 72 hours, you can consider renal replacement therapy, but the evidence for benefit is unclear based on the Akiki 2 trial. Changing towards now modes of renal replacement therapy when the patient does require this treatment, and we embark on this within the ICU. There are a few different ways we can deliver this therapy. First is intermittent hemodialysis, which we're probably much more familiar with. There are also forms like slow, low efficiency dialysis, also known as PERT or prolonged intermittent renal replacement therapy. And then continuous renal replacement therapy on the other end of the spectrum in terms of its duration of therapy. Intermittent dialysis is usually given over 3 to 4 hours, most of the time 3 times a week, but there are higher intensities that can be desired. It leads to the fastest, most efficient solute clearance and fluid removal, requires traditional dialysis machine, generally a water source and no other specialized equipment, and trained staff to run the machine. Continuous renal replacement therapy is any extracorporeal blood purification that is designed to be for 24 hours. And while it does lead to effective solute and fluid removal, it is much slower than intermittent dialysis. It also does require specialized equipment, such as filter sets and solutions, as well as trained staff to run the machine. In between intermittent dialysis and CRRT is SLED or PERT, which is usually given over 6 to 12 hours. It does also lead to effective solute clearance intermediary to the CRRT and IHD examples, as well as fluid removal. It does use a traditional hemodialysis machine and once again requires trained staff to run the equipment. Comparing all these forms of renal replacement therapy, it traditionally comes down to hemodynamic stability and things like ICP that would determine which of these modalities you use. Looking at this diagram here, CRRT is the most hemodynamically tolerated form of renal replacement therapy. And on the opposite end of the spectrum, because of the fluid shifts that occur in the short period of time of 3 to 4 hours, hemodynamic stability is least with intermittent forms of dialysis. When it comes to rates of fluid removal and rapidity of correction of metabolic and acid-base abnormalities, because of the manner in which IHD runs over 3 to 4 hours, this is faster than modes of CRRT. Comparing things like urea reduction, here we see with CRRT, demonstrated by this black line, over time you see a slow, continuous, and sustained reduction in urea and other solutes, whereas with other forms like slow, low efficiency dialysis or intermittent dialysis, you would see a trend over time of increases and decreases between the dialysis sessions, but otherwise effective solute clearance and reduction in urea. So when do we consider intermittent or continuous dialysis? The KDIGO guidelines of 2012 report 2 indications for when to consider CRRT over intermittent dialysis. Based on 2B evidence, they suggest using CRRT rather than IHD for hemodynamically unstable patients. Now, they don't define what degree of vasopressor dependence someone would have to consider CRRT over IHD. And what they do not address in these 2012 guidelines is use of SLED or PERT. But nevertheless, what we do see is that the most unstable patients within the ICU, because the treatment is given over 24 hours, CRRT tends to be the best tolerated hemodynamically over other forms such as IHD or SLED. the second large category of patients that we might consider using CRRT. And again, it has to do with the reduction of urea over time. Urea is an effective osmole, and so shifts in urea may lead to embarrassment of cerebral edema or increased ICP. And to avoid this complication, CRRT is preferred over IHD for AKI patients with acute brain injury, again, based on evidence that is listed as 2B. Importantly, no form of renal replacement therapy has a demonstrated mortality benefit in any study or systematic review to date. And so it is important when we initiate renal replacement therapy to keep in mind our two goals: solute clearance as well as fluid removal. And all the forms of renal replacement therapy can achieve this. Specifically talking about continuous renal replacement therapy, there are several modalities within CRRT that are important to denote. There is slow continuous ultrafiltration, which would be slow continuous fluid removal without use of any dialysate or replacement fluid. This would be for someone with diuretic resistant AKI, but no metabolic need for solute clearance. And again, it's continuous, so provided over 24 hours for effective ongoing fluid removal. There is continuous veno-venous hemofiltration, which would be convective clearance of solutes and replacement with a specialized CRRT solution. There is continuous veno-venous hemodialysis, which is very similar to intermittent, using a countercurrent diffusive mechanism of clearance and given continuously over 24 hours. And then combining both hemofiltration and hemodialysis, the most common form of CRRT we provide in the ICU tends to be CVV-HDF, or continuous veno-venous hemodiafiltration, again involving a continuous 24-hour therapy and utilizing both a dialysate and replacement fluid. Hemofiltration and hemodialysis are best understood in terms of how they clear solutes. Hemofiltration, as mentioned, uses convective clearance, where a negative pressure is applied to a semi-permeable membrane to remove plasma water. And then the plasma water removed is replaced before or after the filter with specialized CRRT solutions. Hemodialysis, such as CVV-HD or CVV-HDF, utilize countercurrent diffusive clearance mechanism of solute removal. The dialysate is infused into the filter at a given rate, and then solutes move across their concentration gradients and are removed in the effluent before the plasma water and blood is returned to the patient. And hemodiafiltration utilizes both convective and diffusive clearance, and therefore uses both a dialysate and replacement fluid, but essentially takes advantages of both forms of clearance of solutes. In theory, convective clearance is meant to remove middle and larger molecules, things like inflammatory cytokines, CK. Practically speaking, this has not been shown to lead to a patient-centered outcome difference. And so while it is theoretical, it does not probably matter all that much in terms of patient outcomes. Showing schematically the different forms of continuous renal replacement therapy, I'll first go over how continuous veno-venous hemofiltration, or CVVH, works. The access from the patient would, through the blood flow rate, pull the patient's blood from a central vein toward the hemofilter. And then the negative pressure would be applied to the filter, pulling plasma water into the effluent, as shown here in the yellow bag. Whatever amount of effluent is removed would be replaced with a CRRT solution that is perfectly balanced in terms of its sodium, bicarb, potassium content, and that could be infused before, pre-filter, post-filter, or pre and post-filter. continuous venous hemodialysis. Similarly, the patient blood flow would be toward the hemofilter here. The dialysate would be countercurrent and would remove, through concentration gradients, the plasma water into the effluent bag, which would include both the dialysate and the plasma water. And through removing down through concentration gradients, the now cleared blood would return to the patient. CVV-HDF utilizes both a dialysate and countercurrent diffusive clearance, as well as convective clearance through application again of negative pressure, semi-permeable membrane, and removal of plasma water, and then replacement pre or post filter or both of a specialized CRRT solution. When prescribing CRRT therapy, we'll go over the basics of this now. A filter set is chosen, and there are different types of filters, some very specialized ones, but the traditional AN69 filters are surface treated or ST150 filters that would be used in most ICUs. You would prescribe a patient blood flow rate very similar to intermittent or other forms of dialysis. The patient blood flow rates are typically between 150 and 300 mils per minute. There are specialized CRRT solutions and any additives that we add, such as potassium, phosphate, or others. The dose, you would prescribe a dose based on the patient's actual body weight, and the recommendations from the KDIGO guidelines would be 20 to 25 mils per kilo per hour of delivered effluent based on best evidence in terms of the intensity of therapy. You would have to prescribe also the solution flow rates based on this dose. And if prescribing the most common form of CRRT, which is CVV-HDF, you would prescribe a pre-filter replacement flow, a dialysate replacement flow, and a post-filter replacement flow rate. You would also prescribe a form of anticoagulation or none, and the options would include heparin or regional citrate. As well, you would prescribe a desired net fluid off, usually on an hourly basis. When overseeing CRRT in the ICU, it is important to do daily checks of the machine alarms, the filter set for things like clotting. Importantly, I tend to look at the filter life and see how the circuit could be optimized. Ideally, filters can last up to 72 hours, and for ongoing effective dialysis, it is important to try to maximize filter life. Things such as your access, where it is located, things like use of pre-filter replacement can help with prolonging filter life. Review of whether you achieved your solute clearance goals, so clearance of lactate, reduction in acidosis, and reduction in potassium would be important things to examine daily, as well as what the delivered and prescribed doses were on CRRT. It's also important to review whether you achieved your net fluid goal off and what your goal will be for the next 24 hours. Also, while rounding on patients and reviewing the therapy in the ICU, it'd be important to monitor side effects from anticoagulation, such as bleeding or development of thrombocytopenia or suspicion of hits. And if you're running regional citrate anticoagulation, monitoring the metabolic effects of citrates and screening for citrate accumulation or citrate toxicity would be an important part of daily care. When to discontinue therapy, usually renal recovery of the patient on CRRT, or if it is felt that the hemodynamics have stabilized such that they would tolerate a different form of dialysis, such as intermittent, or if they've developed renal recovery as defined by excellent urine output of greater than 1 liter in 24 hours without diuretics, or more than 2 liters with diuretics, and no need for renal replacement therapy for 7 days. or as defined by spontaneous decrease in creatinine and no requirement of renal replacement therapy over 7 days. Summary and take-home points. AKI is common in the ICU and associated with worse outcomes. There is no current perfect predictors of need for renal replacement therapy, and we can safely delay renal replacement therapy for patients without absolute indications. When it comes to forms of renal replacement therapy, there is no mortality benefit, and that we should focus on whether we have achieved our solute clearance and fluid off goals. And our decision should be based on hemodynamic stability of the patient and the presence or absence of brain injury leading to increased ICP or cerebral edema. Therapy should be assessed daily and all patients monitored for renal recovery. Thank you. Following my presentation, there have been just a few questions that I wanted to clarify. I'll start with the furosemide stress test. So as mentioned, this is a test in which furosemide is given, and then the urine output is followed after a bolus of furosemide. The urine output criteria of 200 milliliters is a total urine output over the ensuing 2 hours after the bolus of furosemide. Again, over 200 milliliters would be considered a positive test, predicting that maybe they will not advance in their stage of AKI and intact tubular function. The second thing I just wanted to clarify had to do with the duration of therapy for continuous renal replacement therapy, or CRRT. So while I've mentioned several times in the talk, it is for 24 hours, it's 24 hours per day. Essentially, it is truly continuous, and it may run for days or even weeks in some cases, but the machine runs continuously 24 hours per day. The third point of clarification has to do around the fragility index mentioned as part of the assessment of the Elaine trial. The fragility index is a marker of the preciseness of a trial, and specifically a low fragility index can mean an imprecise finding. And in this case, a fragility index of 3 means that a difference in outcome of just 3 patients in one group might make the results not statistically significant. And so it is a marker, again, of preciseness of a trial and robustness of it. Another point I just wanted to clarify had to do with mentioning the rifle classification. The rifle classification is typically used in chronic kidney disease, but the stages, at least of risk, injury, and failure, are very similar to stage 1, 2, and 3 of the KDIGO-Aiken staging guidelines. And so rifle F, or failure, would be equivalent to a KDIGO stage 3 or severe AKI patient. Also wanted to clarify the KDIGO recommendation that was 2B for indications for CRRT over IHD. So importantly, a 2B recommendation is essentially a suggestion rather than a recommendation, indicating that there is imperfect evidence and that following or not following this is up to the clinician, and that there is not a strong evidence basis for these recommendations or suggestions. The very last thing, I just wanted to clarify one of my slides, which I'll share with you now. The summary of when I start renal replacement therapy in the ICU. The second bullet point for patients that don't have absolute indications, a watchful waiting approach, and delayed initiation of renal replacement therapy unless, rather than if, unless they meet these criteria. So essentially not starting renal replacement therapy until they meet these criteria is what I am suggesting and recommending here. Thank you again.